Good noon, and thanks, chairpersons. I've been tasked with talking to you about progress towards elimination of viral hepatitis. So let's first try to understand what we mean by elimination of viral hepatitis. When the World Health Organization in 2016 released the Global Health Sector Strategy on Viral Hepatitis for the first 5 years and which has been extended till 2030, it referred to the goal of eliminating viral hepatitis not as a disease but as a major public health threat by the year 2030, that is over a time span of 15 years. And the way elimination of viral hepatitis as a public health problem was defined was from the 2015 baseline over 15 years, reducing the number of new cases of hepatitis B and C by 90% from the baseline and reducing the number of deaths every year from hepatitis B and C by 65%. And in between there were interim targets for 2020, and those were 30% reduction and 10% reduction respectively. And these targets applied to everyone at risk of viral hepatitis. So they applied to all age groups, all socioeconomic groups, both women and men, and to all populations, for that matter, all countries and that were at risk. So for these impact targets that I showed you in the previous slide, modeling suggested that we needed to achieve certain process targets, and these were a 3-dose hepatitis B coverage in childhood of 90%, prevention of mother to child transmission primarily through birth dose immunization, and to some extent, if possible, where possible, through pharmacological measures trying to suppress the virus in the mothers of 90%, screening of blood donations 100%, use of reuse prevention of 90%, and safe injections 100%. In those who inject drugs, harm reduction strategy including provision of 300 injection devices every year, and most importantly that 90% of those who have chronic hepatitis B or C virus infection would have been diagnosed, and of those who were diagnosed and were eligible, 80% would have been treated. So when we started off in 2015, for some of these we were already doing fairly well, particularly 3-dose vaccination, blood safety and injection safety, whereas for others we had a lot of ground to cover. So where are we today? And I'm going to primarily rely on 2 publications. So World Health Organization a few months ago published a Global Hepatitis Report 2024, and this is a paper from the Lancet Gastroenterology and Hepatology Commission, which was again published earlier this year. So if we first look at the Lancet Commission report, there are 20 countries shown here in red that account for 75% of global disease burden due to viral hepatitis, and they looked at what had happened from 2019 when they had looked at this previously in 5 years, and they devised a hepatitis policy index, and on this they looked at where the country scored, and the range is from 0 to 100%. And this was to assess their progress in 10 key elimination policies. So this looked at the presence of policies, not necessarily action. And of the 20 countries that I showed you in the previous slide, 12 showed improvement over time, 6 were static or virtually static, and in 2 there had actually been a decline. But that's really because what is expected of them has changed, not that the situation has changed. The progress was variable over countries. In particular, Egypt and Brazil had been doing well even earlier, and they continue to do that. And the main thing that changed was that these countries formalized national action programs They started having provision for publicly funded screening programs and for antiviral treatment at the cost that the government would bear or would subsidize. There were also minor improvements in vaccination, injection safety, and policies related to harm reduction measures for persons who inject drugs or are otherwise at a higher risk. So Egypt example is particularly interesting. Is a country with a population of 102 million, or for us in India 10 crores. This is the country which had the highest seroprevalence of hepatitis C in the general population of 14.7%. They started a program in 2018-19. They called it 100 million healthy lives. Sorry for a spelling mistake. This was a mass screening and treatment program for adults for 3 diseases: hypertension, diabetes, and hepatitis C virus infection. By 2020, within 1.5 years, they had screened about 50 million people and diagnosed and treated 1.6 million for hepatitis C virus infection. I must point out that in this program, the seroprevalence wasn't found to be as high as it had been estimated earlier. This led to a reduction in HCV viremia prevalence to 0.4%. So by now they have diagnosed 95% of those who were expected to be infected, and more than 90% have already been treated. Also, the new HCV infections have come down because in the population, fewer infected people mean fewer opportunities for transmission. For hepatitis B, birth dose vaccine coverage has increased, but even though the treatment is state subsidized, because there is no mass screening program, testing program, only 10 to 15% have been diagnosed, and therefore they have not been treated. If we go to the global hepatitis report, if we look at the impact indicators, we can see that new infections have come down by about 30%, from 3 million a year to 2.2 million a year over a period of 3 years. Of these, nearly half the new infections are hepatitis B and nearly half are hepatitis C. And there have been some improvements in vaccination, safe injections, and expanding increase in HCV cure rates has led to some reduction in new infections. However, the number of deaths due to viral hepatitis annually has increased somewhat, and that's because we have not been able to have as much impact on diagnosis and treatment, and most of these, I would like you to notice, are because of hepatitis B. Also, we don't have as good treatments for hepatitis B as we have for hepatitis C, and of course we can't achieve cure. So if we look at the different process indicators, we can see, so this is what was there in baseline in 2020. This is the progress by 2022 over a 2-year period. This is the target for 2025, and that's the final target for 2030. People who would have been diagnosed was 10% in 2020. Remember, our target had been 30% when we started off in 2015. We were supposed to go to 60%, but we reached at the end of 2022 only 13%. COVID-19 pandemic did play spoil sport, but even without that, we would surely not have reached here, and we are far away from where we want to reach in 2030. Those who are eligible and who need treatment, we are still treating only 2.6%, a far cry from where we want to be. Hepatitis C is somewhat better. From 21% diagnosed, we have reached 36%. For treatment, we have increased from 13% to 20%, but still we are far away. If we look at vaccination, this is the newborn vaccination, timely birth dose within 24 hours of birth. We were at 43%, we've reached 45%, and we wanted to reach 70%, and the final target is 90%. Again, we are slow. Vaccine coverage, third dose, we have virtually not changed, but there is only a small improvement required. Now, these data are different from more reliable data for immunization, which come from the VUNIC data. And if we look at, basically there are some regions which are not doing as well. African region, where the birth dose as well as the third dose coverage is low, or the Eastern Mediterranean region, where birth dose coverage continues to be low. And these are also the regions where hepatitis B transmission is relatively high. So we need to work on this. In India, third dose coverage is 93%, so we are actually doing very well, but birth dose we need to improve. If we look at other prevention techniques, number of needles and syringes distributed per person who injects drugs, hardly any change. Blood safety, no change. Safe injections, no change. So we really need to cover this gap. So the global and this is what they say, the global coverage of prevention, diagnosis and treatment has been too slow. The countries have definitely developed plans and adopted WHO guidelines for scaling up, but implementation has been poor, both in terms of diagnosis and in terms of treatment. So what can we do? These fall into 4 categories. Firstly, simplification of care. We need to increase testing while avoiding repetitive testing. It has been seen that in many countries the same groups are being tested again and again, and that should be avoided because that increases expenditure without any extra benefit. We need to roll out simplified strategies for hepatitis C diagnosis and treatment. That means treatment will have to be done by primary doctor, not necessarily by specialists like you and me. We have done that for HIV. I don't know why we are resistant to this being done for hepatitis C. Without that, we will not be able to make a dent. We need to have more availability of point of care tests and reflex testing so that if a person is positive for antibody, the lab would automatically process the sample for doing HCV RNA. We need to have special focus on high risk groups, people who inject drugs and the prisoners. For them, we need to have specific treatment programs, including supervised treatment, because they stop treatment in between. We have done that for tuberculosis, and it should be possible for us to do that for HCV for these groups. Also, we need to do research whether we can have long-acting drugs, including depot injectable drugs for such patients. For hepatitis B, we need to again simplify investigations, monitoring, reducing the number of clinical visits and decentralizing care from hepatologist to a general physician. This would mean use of e-antigen, e-antibody instead of DNA tests, use of dried blood spot molecular tests. Maybe we can skip HCV-CC surveillance or increase the interval for HCC surveillance while trying to treat them. And once a person achieves viral suppression, do we really need to test them frequently for HBV DNA? Because that is what is increasing the cost. That is what makes the person come repeatedly to the hospital, which can be avoided. And again, we need long-acting drugs. For diagnosis, we need to invest in developing simplified diagnostics, point of care tests, rapid diagnostic tests which can be done on finger prick blood sample or on oral fluids. We need tests with quick turnaround time so that they can be done and reported before the person leaves the clinic and then advised accordingly. And we need to have alternatives to molecular testing. This could be dried blood spot testing so that the transport does not need a cold chain, storage does not need a cold chain. We need to use more of antigen testing, especially for hepatitis C. And we need to think whether for developing countries to make an impact, we could actually have tests with lower sensitivity and maybe even qualitative tests for detection of HCV RNA. Why do we need a quantitative test if it can be cheaper, simpler, and done without much of equipment? One major issue is funding. We need about $6 billion for the global initiative to achieve global elimination, but till now we have no funding agencies. So we need to look for some innovating funding solutions, whether they are global or the countries decide domestically to prioritize and spend money on these programs. When we have less money, we need to think of cost saving strategies. So countries need to buy generic antivirals, and also that should apply to private market. We should have generic antivirals available much more easily, and we the physicians need to use those generics rather than using branded costly products. We need to use the management systems, the clinical systems in a approach so that there is a universal health approach, and we use programs that have been developed, for instance clinics for HIV, and also you train the same staff that is providing primary health care to roll out hepatitis B and C treatment programs. And finally, we need to involve communities so that they support these programs, and harm reduction services partly can be done by NGOs rather than by the government. Looking at the drug prices, these are the generic prices in different countries that are available for TDF. You see India is fairly low. Same is true for entecavir, but that's not true for other countries, and also in our countries it's not true for patients who come to you and me who get drugs from a hepatologist. Similarly, for soft Velpa, $76 for 12 weeks treatment, 6,000 rupees. When we prescribe it, do our patients get it? Can that be changed? And that needs to be done. Also, we've learned from COVID-19, we did a lot of decentralized care. We increased lab capacity. In all districts, there are PCR machines. Can we use those now? We learned how to use telemedicine. We learned that drugs could be sent to patients' homes rather than patients having to come to clinic to collect drugs. And we improved our online data collections for COVID. Why can't we do that for hepatitis B and C? We really need to decide and do that. And that will happen when the care happens in primary health care rather than with us, the hepatologists. So what I have to report to you that we haven't made as much progress as we should have, but I think there are means and tools available if we have the wish. Let's decide. If we decide, we'll do it. Thank you.